when
I first was in practice, we used to do a lot of TNAs, tonsillectomy surgery. And we had a little red flag, and we saw that the little uvula thing was split, and the palate was high arch. Something about a submucosal cleft. What is that?
the soft palate, let's start with this way. If you look inside somebody's mouth, the first thing you can see is their teeth. And if you tell them to open real wide, you can see the roof of their mouth. The roof of their mouth has two areas: the front, which is the hard palate, and the back, which is the soft palate. At the back of the soft palate is going to be a little thing that hangs down called a uvula. Now, there are certain times when we have a problem with that soft palate or the uvula, and the uvula, instead of being one little piece that hangs down, can be split, and the soft palate cannot be completely formed, and it would look as though it was a almost clear or translucent, where you can see light through it. That's known as a submucosal cleft. Now, what does that mean? A submucosal cleft is when the muscles that make up the soft palate are not in the right place. The covering of the soft palate is complete, so you don't, when you look at it, you don't see a defect, but underneath that covering there's poor muscle anatomy, and the muscles don't work right. What happens when the muscles don't work right is the palate doesn't close tight against the back of the throat. That's known as nasal speech. So, for example, when children want to say, or anybody wants to say certain words, that they have to don't let any air escape through their nose, say the difference between A and E, and you could ask someone to say they can't say they can't distinguish those two vowels, A and E, and they're going to hear air come out their nose. So
if they were going to consider tonsillectomy surgery, it's a little bit of a red flag. To be very concerned about it. A neurosurgeon like you should be involved in discussion, because sometimes if you do that surgery, that ear could get weakened and split.
Well, the issue of tonsils and adenoids, tonsils are the two lumps that are on the side of your mouth, and adenoids are a little lump that's way in the back of your throat. If the patient has a problem with a cleft, the school of thought is be careful, because if you take out the tonsils or the adenoids, you may
weaken
their airway or give them this nasal speech.
So a person like you, specializing in that area, could be involved in this to make the right decisions, so we don't get this off.
Well, I like to work closely with an ear, nose, and throat, pediatric ear, nose, and throat doctor, and we make decisions, because the reverse is true. Sometimes I need to use some of the structures around the tonsils to improve speech, and so I'll have the ENT doctor remove the tonsils and then come back a couple of months later.
So we go back to the original premise. A team approach seems to be the best approach. More minds, more people, and specialties that relate to that thing would give you the best possible results usually. Is that correct?
Yes. You want a team, and you want a team that sees a fairly large volume of patients, because there's no substitute for experience, and teams that just see a handful of patients now and then, it's hard to keep the interest level up and their experience level up.